Okay, so good afternoon, and thank you for joining us. I'm Jamil Abdulrahman, hematologist in Toronto. Welcome to another CanVector National Thrombosis Seminar. The monthly seminars are hosted live and feature state-of-the-art thrombosis lectures presented by Canadian and international experts. The seminars are accredited by the Royal College, and they're recorded and will be available online. The planning committee of the seminars is listed here. Today's presentation is Innovative Pragmatic Trial Design, the iTADS trial, with speaker Dr. Dean Ferguson. Dr. Ferguson is an established international leader in evidence-based transfusion medicine and clinical trial methods. Dr. Ferguson has conceived, designed, and conducted randomized trials in transfusion medicine that have advanced knowledge and practice in defining the optimal blood product to transfuse, establishing timelines to administer transfusions, and evaluating transfusion alternatives. Throughout his career, he has received over $348 million in peer-reviewed research grants, including 173 CHR grants, over $141.5 million as a principal investigator, including 51 CHR grants, and major salary awards from CHR and the province of Ontario. He is one of the most cited and impactful researchers, having published over 704 peer-reviewed journal articles, many in high-impact journals. The learning objectives for today's presentation are listed here. After the presentation, there will be a short question and answer session. Please feel free to type your questions in the Q&A chat box at any time, and we'll address them later after the presentation. Thank you, Dr. Ferguson, for joining us today. Please begin when you're ready.
Great. Well, thank you, Jamil. I'll just share my screen here. Okay. And you can see that.
Looks good, thank you.
Good, great. Yeah, thank you. And it's great to be here at the CanVector thrombosis seminars. And although I won't be talking about the field of thrombosis, it'll be close to your heart. It's to do with transfusion. And the reason for that is to go over the iTADS trial, some innovations that we used in iTADS trial, combine it with a bit of, not a bit, actually quite a bit of knowledge that we learned through the pandemic and conducting trials in the pandemic, and some ingenuity that came forward, and all together pointing to a new way or a relatively new way of doing trials and looking for efficiency in both their design, but their execution as well. So I'm going to talk to you about the iTADS trial. And this was an innovative trial for assessing donor sex. And what we're talking about here is what the impact of red blood cell donor sex, male or female, on recipient outcomes. So taking a very broad view and seeing what their impacts are on recipient, in this case, mortality. So part of my research, I'm just going to move a window here. Part of my research it deals with trying to find the optimal product. Over 100 million units are collected every year worldwide and processed and administered to patients. Most of them administered to patients. Yet there is actually little evidence on what constitutes that optimal product. And so I got a figure here from Ravi Patel. He's a neonatologist and does a bunch of fantastic transfusion work. And it nicely kind of, a nice picture of all the different elements that can go into that RBC unit. So even the variability of how that unit is processed and stored in terms of anticoagulant preservatives used, the timing of leukoreduction, whether leukoreduction was used. But then we get into storage time, right? How long? Hopefully we brought some clarity to that. In the neonatal world, it's aliquots, so the size of the aliquots and how many to give, etc. There's also washing and irradiation, I should say, of products that still goes on in some centers, a lot of variability. But it's this section here, the donor variability, that we're going to focus on. And so what does age, gender, in this case for neonates, what was CMV status, how do those all affect the red cell product given and administered? So a bit more background. There we go. So there's been some, ex vivo work showing that taking a bunch of donated blood and looking at the differences between males and females, and whether iron levels, whether hormone levels all matter. And it seems to actually does matter, that those agents create sort of different products, if you will, with some with lower hematocrit, increased or decreased hemolysis, and biochemical changes, morphological changes. But there seems to be a difference between male and female, and it doesn't matter the process method, whether it's whole blood filtration or buffy coat depletion. So, some really neat work done about, 7-8 years ago. This was followed up by a large study by the REDS-3 group, or the REDS group, based out of the US, but in an international group. And they looked at 13,000, I think roughly 13,000 blood donors, and looked at types of hemolysis and the differences between males and females. And again, showed, highly significant differences between all measures of hemolysis, whether it was due to storage, osmotic, or oxidative influences on hemolysis, and showed that, again, there was differences between males and females. So this work was brewing in the sort of mid 2000s, and we brought it to studying it here, actually at the Ottawa Hospital, and because we had a fairly robust data system between our data warehouse and an ISIS subunit, which is the provincial administrative data that we could access. So we decided to look at what the effect of blood donor age and sex, both sex and age at the time, on recipient survival. So data here was the big backbone of this, because it was an observational study. And we managed to link our data warehouse data at the Ottawa Hospital with CBS to get the donor data and the donor characteristics. We then matched it up with further data here at the data warehouse in terms of the clinical and non-clinical data. And then we eventually linked all that with ICES, which is our provincial data holders, administrative and soon to be non-clinical data as well. And so we linked all those together, and we took all patients requiring a transfusion at the Ottawa Hospital between 2006 and 2013, and then we followed them up for a couple of years past that. So we had in total over that period about just over 30,500 recipients. Corresponding, we had about close to 81,000 donors that were providing blood to those recipients, and about 190,000 units transfused in total. And we had mean follow-up from the very first transfusion about 2.3 years, and maximum follow-up, because of our time period, of about 7.2 years. And remarkably, this is still, I think, is incredible, proportion of mortality. Anybody receiving, overall, anybody receiving a unit within that time period, the mortality was 43%. So anybody needing a transfusion overall, obviously there's a mix of different patient types and acuity, but their overall mortality was 43%. And we'll get back to that during the trial. So our primary analysis was to look at both donor age and donor sex. What I'm presenting here is on donor sex. And when you took on average, so the study mean was 6 units, and just for the data is incredibly complicated, because there's a mix of different number of transfusions, and within those transfusions, as you can imagine, because it's not controlled for, is different ages, different sexes, and so forth. So to make it simple, we took everyone with 6 units of blood and looked at the difference in survival if all those 6 units were female versus male. And what you can see is that male donors had, male donors in blue here, male donors had a higher survival compared to the female. And the results down below here confer either unadjusted or adjusted, the hazard ratio of 1.08. So an 8% increase in mortality with each unit received. And so they were quite stark findings at the time. Mind you, they're observational. And like I said, because of the nature of multiple transfusions and multiple donor and recipient characteristics, we needed randomized evidence. So we used this then to go on to our iTADS protocol. And what we wanted to bring forward here is obviously the research and the scientific question, but we also want to bring forward that data architecture, because there is a lot of good quality data that's routinely collected that we could use in the trial itself. So that's what we did. We designed at the Ottawa Hospital, which covers three campuses plus the Heart Institute. We designed a double-blind randomized trial evaluating donor sex. And our primary question was, does a male donor RBC transfusion strategy improve transfusion recipient survival compared to female donors in all hospital patients requiring a transfusion? And so our hypothesis was that male would confer a higher benefit compared to female. And then our secondary was to look at subgroups within that. I mean, obviously taking all comers, there's a lot of different patient mix in there, but we also wanted to look at other important clinical endpoints. And then the tertiary was to build capacity to conduct large, innovative, prospective, pragmatic trials in transfusion medicine using routinely collected clinical administrative data. And that was a major tertiary outcome. Obviously, the science comes first, but we can demonstrate we can do this, then it eases the next trials. So as I said, the 3 sites of the Ottawa Hospital, it was a double-blind pragmatic trial. Consent model here is because we were looking at it hospital-wide. That was our question in all comers. We asked for a waiver of consent, and with the ability after the first transfusion to withdraw from the study. And keep in mind that for the first transfusion, it's given at random anyway as part of usual care. We don't give transfusions based on many donor characteristics, such as certainly such as sex and age. So it was just following up on that natural randomization that would occur in the first place. So that's why we put forth the waiver of consent, because we thought we met all of the Tri-Council criteria and believe we did. The study duration was for 2 years, so we would enroll for over 2 years. And so the first patient would be followed up for 2 years, the last patient maybe a day. So that was just the nature of how we ran this study. And we also had an independent data and safety monitoring board to look at data as it was accrued. Again, the interventions were RBCs from a male donor compared to the female donor. And we allocated assignment that was maintained through the entire study. So not just the first hospitalization, but any subsequent hospitalization. And because we thought that was important over the 2 years. And I'll come back to that of why it was so important. And to maximize blood inventory, we used a ratio of 60. 60 to 40 to match the natural blood sort of blood bank product inventory, and so we wouldn't be wasting either male or female. Oh. Okay, and again, we were taking all comers as sort of a broad policy. If we're going to make changes, such big changes to the blood supplier and Canadian Blood Services in this case, we want to make sure that it has broad generalizability before changing any policy. And we did have exclusion criteria too, because we randomized everyone from the blood bank and the transfusion services. They're busy people, and we didn't want to they had to go about their regular business. So if there's an activation of massive transfusion protocol, or those patients that had rare or complex antibodies where there's impossibility to match given the product that was in the fridge, then those were our exclusion criteria. Our primary outcome was survival, looking at time to death, but we also looked at it as a dichotomous outcome at 30 days, 3 months, 6 months, and 1 year mortality. And then again, we looked at other important clinical impacts from a sort of a hospital and policy perspective. And all of these were well validated in the routinely collected data. So talking about that routinely collected data, it was registry based. We use all the data warehouse, CBS donor data and ICS data for both donor pregnancy status and recipient outcomes post discharge. And because of that, and using ICS, all analyses were conducted at ICS with de-identified data. So the results, we ended up enrolling analyzing 8,719 patients from, again, all recruited at the Ottawa Hospital. We actually randomized just over 13,000. And because of our randomization system being from the transfusion service, there is a lot of units that were delivered, particularly cardiac surgery and other major surgeries, almost as sort of standing orders or pre-orders in anticipation that there would be need for transfusion, but many didn't go on to get transfusion. So that was one of our stipulated criteria, that to be in our intention to treat population, you had to receive a transfusion. And so that we had about 8,850 randomized, and there was a few that we had to remove because we didn't have a correct identification number, or they weren't in the provincial registries. Out of all those patients transfused, we only had 2 withdraw their data from after the first transfusion. So in the end, we analyzed we analyzed about 8,850 patients. So baseline characteristics. So at the time of randomization, obviously the recipient sex was fairly well balanced between the two, not donor sex here, because the donor, we manipulated the donor sex of male versus female, but recipient sex well balanced. Same with recipient age. And then where they came from the emergency department, whether they're already inpatients, whether they're being treated as an outpatient, again, all similar between the two groups. About just over 40% were surgical patients, and about 45% were cancer patients. And over that time, from the ICU stays was both a baseline, and any subsequent ICU stays was about 40% as well. So reflective of obviously the patient population at the Ottawa Hospital. In terms of most responsible service, so emergency, because the most responsible service was sort of the first service that the patient would see. The vast majority or not vast majority, over half were emergency, and the others spread out through the other services as already being inpatients when they were randomized, or need for transfusion or randomized. And in terms of comorbidity, we measured comorbidity because it was routinely collected, or the data was routinely collected on inpatients only. And so we used the Charlson Comorbidity Index, and with increasing numbers, meaning more comorbidities. And again, they were relatively similar between the two groups. So the primary analysis, again, we're comparing male, female on mortality. And sort of drum roll, there was absolutely no difference. There's no difference despite all the observational work done by us and a bunch of others, and a bunch of that ex vivo work as well, and coupled with some preclinical animal studies, or many preclinical animal studies, despite all that, we showed no difference in this large randomized trial conducted at the Ottawa Hospital. So overall, at the end, the survival probabilities were close to about 60%, and but no difference along the way. And when you break down mortality into sort of the percentages at each time point, as well as the equivalent hazard ratios, again, there is no difference at any point along the way. And in terms of our secondary outcomes, here we had, again, a number of sort of using routinely collected data, the typical number of hospitalizations, ICU stays, in-hospital mortality. So here you can see when you look at in-hospital mortality, it's about 21.7% for both groups. But remember, our mortality was 40%, or just over 40% overall, meaning that over half actually died outside the hospital or somewhere else. So really important in designing these studies to go beyond hospital discharge, and potentially certainly go beyond hospital discharge, but to also go beyond 28 days as well. So infection, the only area where there was an effect was that there was twice the amount of MRSA. Again, very low numbers, likely due to chance, but very low numbers, supporting lower numbers in the male allocated intervention. But everything else, again, there's a lot of small numbers in here because it was a global hospital population. We weren't focusing on more acute patients, but really across the board, there wasn't anything sticking out that would say that male was conferred a benefit over female, as per our hypothesis. There was a subgroup, though, that caught our attention. And again, we were going in thinking males would confer a benefit over female donor blood. But in this subgroup, if you look at recipients, so the interaction between donor and recipient sex, in female patients, again, there's really nothing there. But in male patients, the male recipients seem to do better with female blood, which contradicts our hypothesis. And we chalk this up likely due to chance. Again, the interaction term was not significant. The interaction term was statistically significant, but in clinical terms, I'm not sure. I probably do chalk it up to chance, or maybe there's an intermediate variable as well, like age. But anyway, worth exploring. So our interpretation of this trial was that the male donor sex was not associated with improved survival, and like I just showed you in that exploratory analysis, there seemed to be some protection of male recipients receiving female blood. So that's the clinical summary of our findings and why we do these trials. But it also points to the the call for simple pragmatic trials and using routinely collected data, thinking about alternate consent models as well. And I think we demonstrated with this trial, like others have as well, but certainly with this trial, that all those are feasible and they're extremely efficient. I mean, the iTADS trial, randomizing 9,000 patients at a single, 3 sites within a single center, albeit a large hospital. We enrolled 9,000, close to 9,000 patients over 2 years, and at the cost of I think it was just over 200,000, about 250,000 in total. So incredibly efficient, both in time-wise and cost-wise. So we thought, iTADS demonstrates that the efficiency of applying these design elements and methods, certainly randomization. Here we randomized from the transfusion service. So when the product was your intervention was being administered, that's the perfect time for randomization. And so we don't have dropouts and people that don't show up and so forth. Obviously using routinely collected data. The novel informed consent. So we had waive consent here, but I think it opens the door, and I really push for alternate informed consent. Again, the regulations don't say, regulations, you need informed consent, of course, but it doesn't have to be written. There's other ways. So there's integrated consent where you're consenting the patients within the clinics and charting that, so it's part of the record, and integrated or oral consent there, or verbal consent. But there's also the opportunity to that we didn't use in iTADS, but which certainly came out through the pandemic, is to identify, enroll, and consent patients virtually as well. And I think it also speaks to the value of master protocols and platform trials. And I'll get back into that in a couple slides here. So we were conducting iTADS, we got the funding, we started pre-pandemic, the pandemic hits. And I put this up here because although we were thinking of innovative designs, and other people were too, we're not the only one on the block, but it's actually the pandemic that put pragmatic trials, put platform trials, but pragmatic trials center stage. And it was done very, very quickly. Within days and weeks of the pandemic, people mobilized to think of, how can we help? What trials do we need on interventions and prevention methods, but most particularly the intervention methods, when there was, 25, 30, 40 different therapies being thrown about as potential therapies in this case. Well, we needed pragmatic trials to sort it all out. And so this was research communities coming together at a national and global level, again, looking for effective treatments. And this was across disciplines, across numerous potential treatments. We also had at the same time government and public health recognizing and championing the need for randomized control trials. I've never seen that before. I mean, it obviously took the pandemic for government and public health to say, geez, RCTs are our way out of this in terms of identifying effective therapies. And it wasn't going to be anecdote or small case series or even U.S. presidential decrees that was going to say that what treatments we should be going with. And along with that, they backed it up with significant emergent funding becoming available, as everyone knows, but also for clinical trials, conducting clinical trials to help combat COVID. And the final thing is, like I mentioned, is these innovative pragmatic trial designs, analyses, and approaches took over. And I remember, March 13th was the Friday. By the 15th, the Sunday night, I was on calls putting these trials together, and they came about very, very quickly. The UK was very fast. They had probably a 2 or 3 week start on it, but then we quickly caught up in North America and Canada. And it was an amazing experience to be caught in all these communities and your collaborators and networks coming together for that cause. So on this slide, I've got what so talking about innovation to pragmatic trials to help the research community out and get efficient answers quicker. What's in blue here are the sort of the traditional characteristics of a pragmatic trial. So a simple protocol, where you have broad eligibility criteria, multiple settings, from clinics to communities to acute care clinics to community center clinics, etc. There's no protocolized care aside from the intervention under study. It's assumed that you're studying effective interventions, that somewhere down the line, the interventions that are of interest have been proven efficacious through phase 2 and phase 3 studies. But traditionally, we look at one at a time. We put it up against usual care. But I think I'll get back to it. I think there's areas to expand there. Efficient and simple data collection was a hallmark of pragmatic trials. Clinical and patient important outcomes. We're not interested in surrogate outcomes. We're not interested in, sort of those biomarkers and lab markers. They had to qualify as clinically important or patient important. And then finally was adequate follow-up time, that we follow up people for good things and bad things to happen to them. And so, again, what's in blue were the traditional hallmarks of a pragmatic trial. I think this is updated in the last few years because we're taking advantage of these new innovations. So when I said effective intervention, we can actually look at multiple interventions. If you look at the platform trials, again, took center stage during the pandemic, is you can be adding and dropping trial interventions as you go on if you have a platform. And I think there's a ton of power for that. And I know many people in the thrombosis world are thinking about that and trying to get them off the ground outside of COVID. The efficient and simple data collection, I think we can amp up because we do have fairly robust electronic health and medical records and powerful health admin data, collecting clinical and non-clinical data. And the question is getting access to it. It's timely access, but there's a lot of power there. And we've got a lot of validation on clinically important outcomes that has taken place within those systems. So locally we built in algorithms to pick up C. diff infections and MRSA infections, and the reliability or validity of those are very, very high. So you can carry those into future trials in different disciplines and so forth. Obviously, mortality is pretty solid as well. But rather than having a written or a web-based or written case report form, when all the data is in the system and you're going to those systems anyway to collect the data, you can cut out the middle person, so to speak. Then streamlined REB approval, I think, is a huge innovation. I think the centralized in certain provinces, we're working hard to streamline that across the country. So there's reciprocity between all the provincial REBs, or provincial REB systems, I should say. And then finally, and I mentioned this before, is let's look ways at when you're doing pragmatic comparative effectiveness trials of everyday interventions, looking for alternative consent models to inform written consent. So pairing that with, again, the advancements we've observed during the pandemic, I'm going to take a couple of the recovery trial and just show you some of those advances. They do apply to other platform trials as well, but certainly the value of pragmatic trials, as I said, took center stage. There's streamlining of these processes for greater efficiency. The research community's coming together, which, in the thrombosis world, I think they've done, they're way ahead of the curve on that and have been for some time. And then when it comes to trial design, picking up on those innovations as well. So the first is taking center stage. And so, the health system and decision, our ministries and in this case, the National Health Service in the UK, it really did take center stage. And this was a letter that went out to all physicians in the hospital system within the NHS. And I'll just blow up part of it here. Is they were saying, we are writing to ask that every effort is made to enroll COVID-19 patients in the national priority clinical trials. So they created in UK, they created 3 platforms, one in primary care, one in hospital settings, and one in ICUs within the hospital settings. So they're here, you get a letter as a physician, you're getting a letter saying, please enroll your patients in these trials. And any treatment given for COVID other than general supportive care should not be currently be as part of a trial where that is possible. So really important message. I know it's COVID. I know it was a pandemic, but again, it's the awareness from our decision makers that clinical trials can make a difference. And this has spawned a whole new way of doing trials. Actually, not a whole new way, capitalizing on all the progress that was happening in the UK beforehand and bringing it into post-pandemic trials. And like I said, while the pandemic is unique, that awareness is there. And I think there's a real opportunity that we need to capitalize on to integrate these platform RCTs or a platform to conduct pragmatic trials within the health system. So the system itself and sites and probably disease level as well, in this case, thrombosis. So the second, advantage or observation that I had is the advantage of streamlining processes. So consent, randomization, data collection, capitalizing on virtual care and its its benefits. And this was seen in the recovery trial. So the recovery trial, this one in particular, covered hospitalized patients and ICU patients. And when you break it down, when you look at what efficiencies they paved the way for, is simple written informed consent. I've talked about alternate forms of written or of informed consent, but even with simple written informed consent, it came down to 4 pages, including essentially a cover page. So not the 20 or 25 pages that nobody understands and truly not informed consent, but 4 pages, very simple. When it comes to web-based randomization, so the randomization was really easy. They had broad eligibility criteria that were confirmed, and it was a simple sort of 1-page randomization for eligibility criteria, screening, eligibility, and randomization form. And when it came to data collection, it was a single online follow-up form of a few data points that was done at 28 days, or if they were discharged or died before, this form was filled out by trial staff. And then the rest of the data all came from the national system, the healthcare and registry data. So huge efficiencies. In the observation of research communities coming together, again, I mean, I think, the thrombosis world has really come together with the networking and collaboration. I think the next steps are at the doorstep, right? I think it's looking at, bringing different creating platforms, bringing those platforms potentially contributing to a single trial. What I mean here is that if there's individual platforms going on in the world, and you're all looking at and each of those shares a common treatment, is bringing those together to have more efficient, more timely, I guess, patient accrual and analysis. And then, because of these platforms, data federation agreements that were worked out during the pandemic, there's great templates there. There's great templates and exemplars for data safety and monitoring harmonization. But a couple other observations were just that inclusive authorship. What's important is these studies get done, not necessarily the order of authorship, but in here they worked out very equitable ways of recognizing everybody, raising early career researchers to the forefront, because this will be their legacy. And finally, just the ability to both learn and do in the face of many unknowns. And I think we learned a lot by conducting these trials. And so that sort of general scholarship needs to be applied to all trials, or as many trials as we can going forward. And then with trial innovation. So I talked about, using routinely collected data, alternate consent models and so forth. But the other innovations were just that growth and acceptability of platform trials. Platform trials have been talked about for a while, but now we really know what they're about, and we know we can conduct them on a national and global scale. What followed too is a lot of those platforms had Bayesian approaches. So, Bayes was finally in the spotlight and in the medical research mainstream, as I have on this slide. because it's been percolating for a while. And I think there's some real advantages to take an Bayesian approach to the analysis. So being able to be sort of nimble of identifying when a treatment is effective or futile, and either adding or dropping those treatments because they are effective early or futile, but also the ability to add treatments as new ones come along the way. But also not just the analysis, but the Bayesian approach to adaptive randomization. So what Bayesian response adaptive randomization is you randomize to control to a number of treatment arms. If there's treatment arms that are doing better, that you randomize more patients into those treatment arms, and so you get your answers in those treatments quicker. And then there was development of novel outcome measures. So getting away from the sort of typical dichotomous outcomes of mortality or stroke or MI or VTE or whatever it may be, to thinking about ordinal scales that capture clinical relevant morbidity and mortality in a graduated way. And those ordinal scales allow efficiency in terms of lowering sample size and so forth. So just looking at time here. To wrap up, I think the pandemic emphasized the power of pragmatic trials, and it's just not the value of pragmatic trial designs and architecture, but the heightened awareness and the value of and need of trials in important patient care and outcomes. And I think iTADS started just before the pandemic, and it's nice to see that some of those efficiencies and innovations can certainly be realized. And again, the pandemic just put it on a whole different pedestal. So I'll wrap up here. A big thanks to the iTADS team, which included Mikhail Chassé, Alan Tinmouth, and Jason Ackers at CBS. Alan Tinmouth's here at the Ottawa Hospital, and Mikhail Chassé is at CHUM in Montreal, U of M and CHUM in Montreal, and the whole host of co-investigators, largely from the Ottawa Hospital, our fantastic transfusion service here at the Ottawa Hospital as well, and the DSMB, Canadian Blood Services, and CIHR for providing the funding. So I think I'll end there, and happy to take any questions and hopefully some discussion around innovative elements in design.
Great, thank you so much for the presentation. So we'll start off with the question and answer. So we've got some questions from an anonymous attendee. The first question is the impact of pre-Ottawa Hospital RBC transfusions accounted for in iTADS?
Yeah, so I think what's getting at there is that so patients that were transfused before they came to the hospital, either the week before, 8 days before, or 8 years before, we didn't account for that. But it should be, we did account for it in terms of the design. It is a randomized trial, so that the pre-transfusion history should be balanced between the male and female groups. And part of that, getting at that is that's why we followed patients on the protocol if they came back to the hospital. It wasn't just for that index hospitalization or index transfusion. If they were discharged and they came back, or they had repeated, on the outpatient wards and so forth, or the medical daycare unit, if they had repeated transfusions, they kept to protocol because of this reason as well.
And then their second question is, what are your thoughts on non-adjudicated outcomes based on admin data diagnostic codes in registry-based RCTs apart from all-cause mortality?
Yeah, so this is an important question, and I tried to convey it within the talk there, that there's been a lot of work validating routinely collected endpoints, right? So within stroke, MI, I think VTE as well, if I can remember. That's what we used the algorithms within the iTADS trial. A lot of work has gone into to make sure that all the elements that can go into that outcome, all the data points that could point you to whether there was a VTE or not, diagnostic and clinical notes and so forth, becomes better and better. But it's an important point. But I think there's been a ton of progress there, and particularly at the Ottawa Hospital Warehouse, where we have scientists who are sort of those big data scientists and clinician scientists that have done a lot of validation work. That's their primary focus.
Perfect. Okay, great. So maybe while we wait for some more questions to come in, maybe I'll ask some of my own. So I really like the idea of the pragmatic trial, very simple and efficient ways to run these trials. I would think you might get some pushback from REB. So for example, on the straightforward consent form, and have you had any challenges from REB, and then how did you get through that?
Yeah, so for iTADS in particular, and I could talk about a couple other examples, but we had our local REB, but we also had the REB at Canadian Blood Services, and both of them were very, very supportive of in our case waive consent. And so waived isn't for everybody, right? Like there's a lot of trials where if you can get individual consent, that's what you want, right? But we felt because of we wanted it from a hospital level, a policy level, all comers, that if we had to get individual consent at each transfusion, it was just totally impractical. So they were actually supportive, but I have to recognize that is a unique case. But when it comes to integrated consent, our hospital REB or Ottawa Community REB has been incredibly supportive, and so supportive of allowing it when the circumstances should allow it, and then looking at our scripts and so forth. They've been incredibly helpful, and so it's now it's being used elsewhere outside of Ottawa, and I think we just need to keep pushing that envelope, because what's important is you have proper informed consent that recognizes the patient autonomy. It just doesn't have to be written informed consent and 20 pages when if these are common therapies, you want to cut to the chase why you're doing this trial, right? It could be harm benefit cost savings, and so you fulfill all the requirements of informed consent very quickly. And I love the concept of integrated consent. And Scott Kim, it was an article that Scott Kim from the NIH, an ethicist there, that wrote and published in the New England Journal, and I think it's a game changer. So yeah,
Definitely. Can you tell us a bit more? So you have a large data framework. So I think it was the auto hospital data, CBS data, and then ICS data. Were there any challenges in making this big data framework, and how did you get through those?
Yeah. So the challenges are it's a lot of rolling up the sleeves and identifying all the data points, where they're going to come from. And again, we're very fortunate that Ottawa Hospital have a robust data infrastructure. Now we have Epic, and hopefully we'll get over the bumps and bruises of that, but I'm pretty confident that we'll get there. But we have a lot of, so it's not just we have the data science elements to our data structure. It was built with that in mind, the hospital needs and then the research community needs. So bringing the hospital data together with Canadian Blood Services was pretty straightforward. And then we turned it over to ICS. So that's our provincial health admin center. Not sure what the proper, I'll say a center, or holdings, I guess. And because of they were going to do all the matching and it has to be de-anonymized, they have to do the analysis. And so it's not they'll match up the data and kick it back to you and you do the analysis. And so that takes, it took us almost 2 years to do that matching, because the holdings within the provincial database for cancer outcomes, like mortality, is updated every sort of 3 months or so. Cancer outcomes are 6 months or a year. And so that took a lot longer than I anticipated. I thought, we'll get our data set ready, we'll send it to ISIS, and we'll have results in a couple of weeks sort of idea, or a few weeks. That wasn't the case. So we need to get better at that. And there's a lot of work going on in that area, not just in Ontario, but across the country with the HDRN initiative and so forth.
Good to hear. Okay, great. Got a few more questions coming in. So what strategy did you use to translate this information to the local clinical community, and what was their response?
So what strategy did you use to translate this information to the local clinical community?
Sorry, that question came in a couple minutes ago. I think it might have been pertaining to, let's see, this information. I think it might be pertaining to when we were discussing the REB. I'm not too sure, sorry.
Yeah.
Why don't we here? Let's come to the next question, and then maybe whoever asked that, you can confirm what you were referring to there. Okay, we'll come back. So another question from Leslie Keith. In Calgary, we are allowed to do virtual consent via REDCap, including online signatures, but we aren't allowed to get oral consent if there is any database involved in the outcomes. Any guidance on how to navigate the differences in ethics board restrictions?
Yeah, I probably have to know a bit more specifics, but I don't know, but we aren't allowed to get oral consent if there is any database involved in the outcomes. So I mean, to me, if it was pre-specified, this would be part of the disclosure in your oral consent. So it's a catch-22 here, but that would be part of the disclosure. Part of the script in integrated consent quickly goes over the study, why the study is being done, and obviously all the other informed elements of informed consent. But in there, you would say, this is the data we'll be using, from the hospital. We'll also be tapping into provincial databases. And that should be, on the face of it, I think that should be fine. And that's what you would take to your research ethics board. But maybe it's a bit more, maybe I'm not understanding it properly, but that the important thing is to taking all these issues and getting a research ethics board that will entertain the issues and help you and be supportive. But it also depends on the question you're actually in the particular trial and so forth. But in the pragmatic world, we just need to be pushing this because patients love it. Our local work. So I do a bunch of these integrated consent trials in oncology, mostly breast and prostate cancer, and the patients love it because they're involved in research. We've got, the involvement goes from it's poor, and you take breast cancer trials. I think it's like less than 5% of patients go into trials. With these pragmatic designs, many, many more patients go into trials, and they're happy that they're involved in trials, not just on first-line therapies. These are, pragmatic supportive care and so forth, but they love being in trials, and they love being asked to participate in trials. And so we have, I think last count, about 91% satisfaction rate of being into the trial. So all that needs to be, and when I spoke to various people across the country, and usually REBs are there and so forth, we just need to be, as I say, pushing it. We just need to be presenting this and working out, local precedent and what can be done. Yeah.
Perfect. Okay, so we'll go back to that previous question. So the question was in regard to the results of the study. So the question again, what strategy did you use to translate this information to the local clinical community, and what was their response?
Yeah, so we've presented it a few times to different groups within the Ottawa Hospital. We have a Center for Transfusion Research. We've published, we circulated the publication, and that's about it right now. The interesting thing too is we wanted to broadly, and it's been in the Ottawa Hospital newsletters and so forth. Here, because it was very difficult, we didn't know, we could identify all the patients. But the one-on-one, getting back to the patients, not the clinical community, but the patients, getting back to them with results, which we tend to do with our trials. We haven't done that. It was broadly sort of community. With the clinical communities, it's just been rounds and presentations, newsletters, etc.
Perfect. Okay. And we have a question from Brian Rowe. He says the reason the NIHR was so successful with the recovery trial was the CT infrastructure that exists for a long time in the UK. As expected, clinicians around the world pivoted to help during COVID-19 because that's what they do. I don't think you can realistically expect it to continue without support in the future. What strategies do you think should be adopted to support clinical research in the future?
Yeah, great point. And again, like I pointed out, the pandemic is clearly different, but we need to capitalize. We can show what we've done, right? And I think I do think it is funding infrastructure. I think it's base funding for clinical trials to not just academic but community hospitals. I think it's the integration into our information systems and sort of IS and IT systems to make this easy, right? We're talking about trials of already proven effective, whether that's true or not, effective therapies that are out there, and your choice between different agents, different supportive care agents, whether it's antiemetics or infection control, whatever it may be. I think we can better integrate into routine care through IS and IT systems, and a general awareness and buy-in that these trials are important and they're cheap. The lever is randomization within these information systems. That's all it is. Maybe a bit of extra data collection, but I think this is what we need to be thinking about. And the money that Canada's response to the pandemic in terms of clinical trials was the $250 million spent, $250 million clinical trial fund as part of the biological life sciences strategy. I think that's where we need to advocate. A lot went into training and sort of national leadership through the ACT consortium, and that we need to be advocating for these ways. And certainly part of our ACT consortium is getting decision makers or provincial health authorities and governments to the table and seeing the value in this. That's exactly, as Brian correctly points out, that's exactly what they took advantage of in the UK. And I think it just serves an excellent example. And before it's too much of a distant memory, I think we really need to push that here. And that's where the disease networks, such as CanVector, I think can have a role.
Agreed. Yeah. Okay, perfect. Great. And Brian says, please keep advocating because austerity budget are on the way. Okay, great. So we're coming up to 2:00. So thank you so much, Dr. Ferguson, for your presentation today. And thank you everyone for joining us in the seminar. And we look forward to seeing you again at the next CanVector National Thrombosis Seminar.
Great. Thank you. Thanks for listening.
Thanks, everyone.
Bye-bye.